Move over nearer, you feel like I'm in trouble.
I just leave you so I know you're in the camera.
Yeah.
It doesn't really matter. Okay, so let's go for the paediatrics, obviously not the shark bite,
Sure, yeah.
because that was all good, but the other. So, can you define status epilepticus for me?
A seizure that continues actively for more than 5 minutes, or a series of seizures where the person doesn't regain GCS-15 in between them.
Fantastic. Why is status epilepticus considered to be a medical emergency?
The continuing seizure causes the person to have extreme workload on their body, so they can become extremely tachycardic, hypertensive, they can have tissue damage, they can have bone damage, leaves them prone to rhabdomyolysis and injuries from continuous seizure activity, and hypoxia and hypoperfusion to their brain, leading to an acquired brain injury or brain injury from the continuous seizure activity. And then there's also the concern about the cause of the seizure, so that can be identified and addressed.
Okay. Are there any, if you think about a status and I say neural death.
Sorry. You don't need anything.
No, thanks, honey.
Thanks.
Yeah. So neural death.
Mm-hmm.
What causes that specifically down at cell level?
So it's the neurons are hyperexcited. They're firing in an uncontrolled manner. They're not having time to rest or depolarize adequately between continuous activity, so they can become damaged. They can like the individual cells become damaged and exhausted, so they end up edematous and expelling their contents and causing a global cerebral damage.
Okay. Can you tell me at least 4, it just says 4, medications that are lethal to peds if ingested in small quantities?
The GLIC group of diabetic medications, the tricyclic antidepressants, some of the like drugs like clonidine that are for hyperactivity, and also elderly people take them in blood pressure control. Products like essential oils, eucalyptus oil. Did you say drugs specifically?
Yeah, more drugs.
Yeah, sorry.
Medications. Yeah.
And the beta blocker group, calcium channel blockers, like propranolol, are lethal.
Okay.
Small doses.
Have the intern describe the clinical presentation and management of at least one patient. Okay, so I'm going to pick TCAs, because you said TCA was an example of something that they could have a smaller amount and then die. Can you tell me the clinical presentation and management of a PED?
So a child with TCA overdose could be as little as 1 or 2 tablets. Initially, the first presentation very early on would be an anticholinergic kind of pattern, so they'd be tachycardic, possibly agitated, and as the drug takes effect and more of it is absorbed, their tachycardia would increase and their QRS can widen. You see initially changes in like a terminal R wave in AVR, and as the QRS complex widens, sodium channel blockade increases, and that also leaves them prone to seizures and lethal arrhythmias, wide QRS eventually widening into a sine wave.
Great. And how are you going to treat little Maxie
Um,
who presents like that?
So you treat them by managing their initial symptoms. So
Mhm.
if they're tachycardic, if they're hyperthermic, you manage their symptoms initially. If their QRS is widening or if they're having seizures, you get sodium bicarb, 1 milliliter per kilo. So max is 22 kilos, you get 22 mils.
Okay, cool. What's the difference between a generalised and a focal seizure?
Generalised is across the entire brain, whereas a focal seizure is an area, a specific small area of the brain, and the presentation is different. With a focal seizure, they're usually conscious, but they have a twitching or an automation or a local presentation. Whereas with the generalised seizure, they're unresponsive and it's their entire body is affected.
Okay, and what clinical signs of seizure may be present in the paediatric population?
They're harder to see seizures in. The eyes moving, like a nystagmus going both directions. They can have a small amount of twitching, so it can just be a hand or an arm, or a fixed deviated gaze, or like a tonic, so where their jaw or their neck has increased tone, but they're not actively moving in the way you'd normally expect, like an epileptic adult to.
Good. Now to Big Max. What was wrong with Big Max?
I think Max had a cerebral hemorrhage. Shirley Max. She complained of a severe headache, and her husband described migraine, so I don't know if there was more than the headache, whether she had an aura or whether she had some focal signs, a weakness or numbness or anything like that would present with initial, like a subarachnoid or an intracranial hemorrhage. And then she was alone for a few hours, so we don't know what happened in the intervening time. And when she was found, her level of consciousness was affected. Her blood pressure was on the low side, so she didn't appear to have raised intracranial pressure. Her presentation didn't fit with raised intracranial pressure, but it did fit with a cerebral damage, and there's a possibility that it was a big cerebral infarct. Not necessarily hemorrhage, but my bet was on hemorrhage with her level of consciousness. And the other possibility is something like an aortic dissection, dissecting up her internal carotids, affecting a large area of circulation to her brain.
Okay. So, 4 interventions or considerations in the management of an acute TBI or cerebral bleed, and then say how each of those interventions would affect patient outcome.
So question again, sorry.
Yeah, it's badly worded and I didn't help. So 4 interventions or considerations in the management of an acute TBI or a cerebral bleed. So 4 different things you would do to them or consider doing, and how would that then affect patient outcomes?
Yeah. So the TBI, avoiding hypoxia is extremely important. The hypoxia causes further vessel dilation in the brain, and increases the intracranial pressure.
Okay, so what?
So making sure they're oxygenated is the intervention you can do. That involves managing their airway, opening their airway, maintaining their airway, and making sure they're breathing adequately, so their ventilation is adequate.
Okay. Is there a SpO2 you'd like to make sure it's above if you could?
We'd like to make sure it's above 92.
All right. Cool. Another one?
You need to avoid hypovolemia or poor perfusion, poor delivery of oxygen and nutrients to the damaged brain. So fluid replacement to aim for a blood pressure of 110.
Great. Do you know or a
A
map?
map of over 65.
You'll want to check that. I shouldn't have asked you. Above 90. No, that's
A
not
map
right.
above 90, that's cracking.
More errors. Yep, you're right. Okay, another one.
You want to prevent any obstruction to venous outflow from the brain. So restrictive collars, restrictive tube ties,
Yeah.
clothes that are restrictive, anything that's restricting venous return from the brain. You need to make sure none of them are tight is the intervention, and sitting them at up to 30 degrees.
Okay.
So there's drainage, there's adequate drainage.
Yeah.
And then the other option is a neuroprotective rapid sequence induction to avoid, so that essentially turns off the brain, rests the brain, and it's neuroprotective, and that the neurons aren't firing, they no longer have the same demand for being well perfused, and that they can be arrested by a general anaesthetic.
Okay, what's a subarachnoid hemorrhage, and what are the signs and symptoms of it?
Subarachnoid hemorrhage is a hemorrhage in the subarachnoid space, so that's below the arachnoid, between the arachnoid and the pia mater of the brain. It presents with generally a sudden, severe, worst headache ever, described as a blow to the back of the head. It often presents with an altered level of consciousness. It can present with like the symptoms of a severe headache, nausea, vomiting, neck stiffness, photophobia, changes in level of consciousness, and changes in, it can present with like symptoms similar to a stroke, so neurovascular deficit, neurovascular is the wrong word, deficit to limbs or the face.
Okay. What's the most common cause of a subarach?
It's usually a berry aneurysm in the subarachnoid space, and it can rupture for no particular reason, or it can rupture with trauma, or with a spike in blood pressure, or a continuously high blood pressure, or hypertension.
And do they often seize?
Yeah, they can, depending on how irritating the hematoma is around the subarach, or if there's intraparenchymal bleeding associated with it, bleeding back through the vessel into the cerebrum.
Okay. And here we go. What clinical evidence is there for therapeutic cooling in the pre-hospital setting?
There's been studies in traumatic brain injuries about cooling patients. It was thought to be very successful. I don't know the name of the studies, but what's been found is that avoiding hyperthermia is more important than, or is more valuable clinically than cooling patients to a set temperature. The trials that happened cooled people to all different temperatures and at different rates, and actively and passively, so they're not entirely comparable. But what has been established is hyperthermia is damaging.
Okay. Do you know what the Cochrane review said about the benefits of cooling?
That there isn't evidence for it at the moment in the pre-hospital setting.
Okay. Beautiful. Are we involved in the trial for cooling? Therapeutic cooling?
I think it's been stopped. Patch, prophecy, and polar, yeah.
So, do you know what that was trying to? Do you have any of the parameters of that, of how much they were trying to lower temperature to?
I think for most of the trials they were aiming to lower it to 34 degrees, but I'm not sure exactly what polar was.
Okay. Good. I don't know if polar's on anymore either.
I think it stopped.
I feel like
I
it
certainly
did.
haven't seen it on any of the